Good morning, ladies and gentlemen. This lecture is regarding vernal keratoconjunctivitis. It is a severe chronic allergic condition that lasts for at least a decade of a child's life. If it is not managed properly, a child can have sight threatening complications. Hence, there is a great need to simplify and standardize its management in order to reduce the complications resulting from both the disease and the various treatment modalities that have been available to date. We have been blessed with a healthy ocular surface in which the cornea is a totally avascular, clear structure that acts as a smooth polished surface to perfectly allow the light to enter the eye and enable us to see clearly. But any chronic inflammatory condition of the conjunctiva will eventually affect the cornea. The concept of ocular surface is extremely important to be understood. Ocular surface involves the cornea, sclera, covered over by the conjunctiva, and since this ocular surface is constantly exposed to the drying effect of the atmosphere and the environment, it has to be kept moist by a healthy tear film. The tear film lines the lower lid margin as the lower meniscus, and the upper lid comes down and closes onto the lower lid, creates a vacuum between the closed eyelids and the globe, and that vacuum picks up the tear film from the lower meniscus as the lids part at the end of the blink and the upper lid moves up to its normal position. It drags the tear film and spreads it uniformly over the corneal surface, and in the process makes the cornea smooth and a polished surface. So a normal ocular surface involves all these five structures, that is the cornea, uh, the sclera, conjunctiva, the tear film, the eyelids, and the lacrimal drainage apparatus. Cornea is clear because it is an avascular structure. The blood vessels they stop short at the limbus and are prevented from entering into the cornea because of the tightly packed multi-layered corneal epithelium as well as the stroma. The special structure of the corneal epithelium needs to be understood clearly as this is an integral part which maintains the clarity of the cornea. The surface epithelial cells have interdigitating borders that are joined together by tight junctions. And these tight junctions they prevent any ingress of fluid or bugs into the corneal epithelium as well as the stroma and maintain the hydrophobic nature and clarity of the cornea. The corneal surface epithelium is non-keratinized and it can quickly dry up if it was not for the presence of the healthy tear film. As I told you, cornea is an hydrophobic structure, which means that it normally repels water. But it is made hydrophilic by the special characteristics of the surface epithelium. As you can see in the diagram, the surface epithelial cells they are covered over by the microvilli, and these microvilli they increase the surface area of the corneal epithelium so that the tear film can adhere to it smoothly and uniformly. These microvilli, they are covered over by a layer of protein called the glycocalyx, which is secreted by the corneal epithelial cells. It is a charged layer and to this charged layer, the mucin, which is produced by the conjunctival goblet cells, attaches. So the in the picture you can see the yellow color, which are the microvilli, and they are covered over by a green layer, which is the glycocalyx, to which these mucin attaches, and this mucin, which actually forms the deeper layer, the third layer of the tear film, this makes the cornea hydrophilic. And this glycocalyx mucin complex allows the aqueous layer of the tear film to stabilize over the cornea, to cover the corneal surface epithelium uniformly, and prevent it from drying. A healthy tear film not only keeps the cornea and the conjunctiva moist, it forms the cleaning function as it wipes off any debris, foreign bodies, dust, or bugs which gain entry onto the ocular surface. The aqueous layer has complement immunoglobulins, cytokines, isozymes, and mucins which attack any bug that gains entry onto the ocular surface. The mucins engulf that bacteria or the fungus or the virus, and then the aqueous component just washes it off the ocular surface and prevents it from gaining entry into the eye and producing disease. Also, since the cornea is an avascular structure, the tear film supplies the corneal epithelium with oxygen, glucose, and amino acids. So hopefully now you can understand how important the tear film is to allow the ocular surface to maintain its function. If the tear film is absent, then the cornea will lose its luster, it will be dull, and it will develop microerosions, as you can see in the picture. All that green staining over the corneal surface are the tiny microerosions, and then they can enlarge and the whole cornea can be destroyed. In the upper picture, you can see the reduced tear film breakup time. When you instill a drop of fluorescein, the fluorescence should be uniformly covering the cornea. But if in between a blink, dark islands appear in the fluorescein, this means that the tear film is breaking up at that site. And later, when this dry spot will continue to remain dry, then these microerosions, they appear on the cornea. In order to understand the pathogenesis of conjunctivitis, it's very important to know the normal structure of the conjunctiva. So the conjunctiva is, it's got two parts, the palpebral and the bulbar. The palpebral part covers the eyelids, the marginal part, that lines the lid margin, and then the tarsal conjunctiva, which covers the undersurface of the tarsal plate, and then the forniceal conjunctiva, which has got the stem cells as well as regenerating potential, and then is the bulbar conjunctiva, which lines the eyeball, stopping short of the limbus. The epithelium of the conjunctiva is specialized makeup or made up of pseudostratified columnar epithelium with scattered goblet cells, and these goblet cells are extremely important to produce the mucins that line the tear film, as well as the free mucins which are circulated in the aqueous component of the tear film and perform the protecting function. Underneath the epithelium is the adenoid layer, which has then aggregation of lymphocytes as well as the important memory cells. These memory cells are extremely important in potentiating the allergic or the autoimmune reactions in the cornea and the conjunctiva. As these memory cells, they can be reactivated anytime they are exposed to an allergen or an antigen. Underneath the adenoid layer is a fibrous layer, and this is made up of fine collagen and elastin fibers. So, conjunctiva is an extremely delicate structure, but a very, very important structure for for maintaining the health and integrity of the ocular surface. It not only protects the sclera, as I've just mentioned, it secretes mucin, it is highly vascular and supplies nutrition to the underlying sclera as well as the peripheral cornea. It has got the important lymphatics which drain aqueous from the anterior chamber into the aqueous veins and out into the episcleral venous plexus and maintain the intraocular pressure. And most important, at the limbus, it has the pluripotent stem cells which are there to renew the damaged conjunctival as well as the corneal epithelium. Corneal epithelium is renewed every second to third day, and these healthy epithelial cells, they come from these stem cells which are located in the crypts of the limbal epithelium. So now coming back to the topic of VKC, a patient comes to you in the clinic with a red irritable eye, and you have to decide whether it is an allergic conjunctivitis, a bacterial infection, or a viral infection or a toxic reaction. The presence of pus in the eye should immediately tell you that it is a bacterial infection, particularly if it is unilateral. So that discharge, which is matting, causing matting of the eyelashes, is produced by the fight between the bacteria and the polymorphonuclear leukocytes, and this pus gives you the clue that it is a bacterial infection. Uniocular nature and pus. Then the other scenario is the presence of a skin rash that is usually produced in herpes zoster or herpes simplex infection. Herpes simplex infection, the rash is localized to a single dermatome, while in herpes zoster it would be more widespread. Then you have to look for any signs of blepharitis. And then allergy, it usually affects both eyes. So by a good history and a proper examination of the eyelids, the lid margin, and the ocular surface, you can easily get your diagnosis and you can manage your patients properly. Oh, how is an acute allergic conjunctivitis produced? Allergens in the form of pollen, dust, insect fomites gain access to the conjunctival sac where they are exposed to the eosinophils and basophils, and they trigger the release of histamine from mast cells. This histamine then causes an acute inflammatory reaction in the form of vascular dilatation and leakage, and with the production of watering from the eye, as well as the vascular congestion produces a boggy conjunctiva with lid swelling, and this will be seen in symmetrically in both eyes, and you can easily make your diagnosis. Because of the presence of memory cells in the adenoid layer of the conjunctiva, the initial memory of this attack will remain in those memory cells, and whenever the child is exposed to the same allergen, this acute type 1 hypersensitive reaction will be mediated immediately, and the acute conjunctivitis will start. Mostly it is seasonal, as it gets worse in the season where the pollen is more, or in the hot environment. And in every case of conjunctivitis, the pathology is almost the same, in which the first response is the vascular dilatation and leakage in response to the histamine. And these leaking, engorged vessels will invite either the polys or the lymphocytes or more of the eosinophils, and the conjunctival tissue reaction will occur in the form, or and there will be discharge. And looking at the discharge, whether it is water, pus, mucus, mucopus, or blood, you can easily make your diagnosis. In acute allergic reaction, it's mostly the eosinophils or basophils and mast cells that are involved. But when the allergy gets chronic, then lymphocytes in the form of B and T lymphocytes are involved, and the tissue reaction is. If you look at the surface of the conjunctiva, the palpebral conjunctiva, you can see papillae, which are the red gelatinous raised lesions present both on the lower as well as the upper tarsal conjunctiva, and they comprise of a central core of engorged blood vessel, which is leaking water and fibrin, and because of which the overlying conjunctival surface gets elevated and red and velvety. The papillae are present in any kind of conjunctivitis, and they indicate that the conjunctiva is reacting to a bug or a toxic reaction. On the other hand, the follicles, they are aggregations of lymphocytes. As I told you, lymphocytes are present in the adenoid layer. So they lift up the surface epithelium of the conjunctiva, and they are pale and shiny. They may be present in the lower conjunctival fornix and chronic drug toxicity, while they are present on the upper tarsal conjunctiva, and it can be seen by everting the upper lid in chronic adenoviral conjunctivitis and acute or chronic chlamydia infection. So, coming to the pathogenesis of vernal keratoconjunctivitis, it affects all conjunctival layers. This is in comparison to atopic conjunctivitis or acute allergic conjunctivitis, in which only the epithelial layer or the adenoid layer is affected. But in case of Vkc, the epithelium undergoes hyperplasia and desquamation. The adenoid layer has infiltration with eosinophils and lymphocytes. The stroma, underlying stroma, it starts laying down fibrous tissue because of the ingress of fibroblasts, and the conjunctival vessels proliferate and cause a chronic reaction. VKC, though, is a chronic condition, but it has acute flare-ups in which the exposure to allergen in the change of environment or the change of season, the allergen gains access to the conjunctival tissue, where it reacts with the eosinophils, mast cells, and basophils to release histamine, and that causes an acute inflammatory reaction with the vasodilatation and release of cytokines and leukotrienes. These cytokines and leukotrienes, then they initiate the migration of T lymphocytes and more of B lymphocytes into the adenoid layer. And they then initiate a chronic inflammatory response with the formation of follicles. Similar reaction is seen at the limbus in the form of limbitis, and this focal inflammation at the limbus, it gradually increases from 4 clock hours to 6, and then produces an annular limbitis or limbal inflammation, and this then affects the stem cells which are present in at the limbal crypts, and it not only affects the conjunctiva but also starts affecting the cornea, and because all these leukotrienes and cytokines, they are toxic to the corneal epithelium as well. Because of limbitis, the elevation at the limbal area prevents the uniform spreading of the tear film over the cornea. In addition, because of chronic conjunctival infection, the conjunctival goblet cells are not producing healthy mucin, rather they are directed to produce altered ropey mucus. So, in the presence of lack of mucin covering the glycocalyx, the tear film cannot line the corneal surface epithelium. The cornea gets dried up, and the added toxicity by the cytokines, this results in a chronic inflammation of the cornea as well, which is apparent in the form of punctate epithelial erosions initially, and these erosions, they can then enlarge and produce shield ulcers. The fibroblasts and macrophages then involved in later stage of the disease in the fibrous layer of the conjunctiva, and they cause subepithelial fibrosis and thickening of the conjunctiva with further alteration in mucus secretion and loss of goblet cells, which in further affects the tear film and the cornea, and a vicious cycle is set up in which more conjunctival inflammation causes more fibrosis and more loss of mucin and more loss of the healthy tear film. In the pathogenesis of Vkc, it's important to understand it's not just the conjunctival inflammation that needs to be treated, but it's the chronic inflammation of the conjunctiva secondarily affects the tear film. So, unless the tear film is replaced, it is restored, and the conjunctival inflammation is reduced at the same time without producing any harmful effects from the therapy, the condition cannot be controlled and complications prevented. So, to enlist a few complications, the altered mucus and the tear film instability is causing dry eyes. Limbitis with the loss of stem cells further affects the cornea. The limbitis opens up the spaces between the tightly packed corneal epithelial cells as well as the stroma, and the vessels from the limbus, they start creeping in, resulting corneal vascularization. These vessels, they start leaking as well inside the cornea, and the cornea gradually loosens its clarity. It develops opacities. So the combined effect of corneal vascularization and opacification, and along with loss of stem cells, it thins the cornea. The cornea can develop ectasia. The constant rubbing of the eyes by the patient because of itching raises the intraocular pressure, and the thin cornea will bulge out at places causing intractable astigmatism. And all these complications ultimately result in loss of vision in that eye. The added insult caused by the steroids, which are used topically to control the inflammation, cause glaucoma, further corneal thinning, cataracts, and loss of such an eye. A patient of VKC needs proper diagnosis at first presentation. The severity of the disease has to be graded as has been outlined very nicely in the paper, which the reference of which is given below. and is also mentioned in the guest editorial of the patron, Professor Pardeep Sharma. So VKC has to be graded clinically into mild cases, which are only symptomatic with itching, rubbing, and discharge and watering, and the only clinical sign is papillae. Then into moderate cases, which are symptomatic with papillae, but they have the appearance of focal limbitis, which is less than 6 clock hours, or with fine punctate epithelial erosions, but the disease is still focal and can be controlled. It should not be allowed to progress further from this stage. Then the severe disease is in which the cornea is severely affected with large cobblestone papillae and limbitis more than 6 clock hours. The combined effect of the limbitis which affects the limbal stem cells and the cobblestone papillae, which constantly rub on the cornea, result in producing coarse corneal erosions as well as the pannus. And finally, the blinding VKC is the one in which has shield ulcers with annular limbitis of the 360 degrees of the cornea, conjunctival granulomas, severe corneal vascularization, and scarring. This is the end stage at which hope nothing can be done really. This slide shows how you can easily distinguish between atopic or acute keratoconjunctivitis in comparison to the vernal keratoconjunctivitis. So AKC is an acute type 1 histamine reaction which only prevents with itching and watering of the eyes with only papillae, and all it needs is antihistaminic eye drops with mast cell stabilizers, plenty of lubricants that should preferably be kept in the refrigerator and instilled into the eye as cold. Ice packs will help reduce the vascular congestion and will alleviate the condition in no time. On the other hand, VKC is both acute and chronic type 1 and type 3 inflammatory response, which involves not only the histamine but also the B and the T lymphocytes. There is severe watering, itching, ropey, mucus, and involvement of cornea and cobblestone papillae on the everted upper lids. It needs, in addition to antihistaminics, mast cell stabilizers, lubricants, ice packs, chronic long-term immunomodulation. If this is not done, then it can cause horrendous corneal complications and irreversible visual loss. This slide outlines a different pathogenic mechanism of an allergic reaction, bacterial conjunctivitis, as well as viral infection. Allergic reaction is mainly IgE mediated with histamine. In bacteria, it's the involvement of polymorphonuclear leukocytes, which produce the purulent discharge, while viral infection involves the cytokines which produce acute inflammation with exudation of plasma fibrin. So you can easily distinguish the three major kinds of conjunctivitis. The bacterial is usually unilateral with purulent discharge and papillae. There are no lymph nodes or follicles formed. An adenoviral infection is usually bilateral with watery, itchy eyes. There will be follicles and enlarged preauricular lymph nodes. An allergic reaction is also bilateral with watering and itching with papillae but no follicles. But when it is VKC or a chronic reaction, then follicles will be present and there will be mucoid ropey discharge. So the main distinguishing feature between acute allergic conjunctivitis and VKC is the extent of involvement of the cornea. Important steps in the management of a patient with VKC is to treat according to the clinical grading or severity of the disease. If the patient presents to you with a mild conjunctivitis, then patient education regarding the chronic nature of the disease. You have to teach them regarding personal hygiene. The children, they should avoid hot dusty environment. They should wash their hands as soon as they come back from playing or from school. They should always have clean tissues or handkerchief in their pockets to wipe their eyes. They should not rub their eyes. The rubbing of the eyes becomes habitual, and it not only results in more histamine release and more vascular congestion, lid swelling. It also raises the intraocular pressure. It can cause ptosis, as is shown in the case report which is presented, and it also causes the corneal ectasia and promotes keratoconus. So rubbing should be avoided by giving antihistamines and teaching the children not to rub their eyes, telling them how harmful it is. In mild cases, double action drugs like antihistamine and mast cell stabilizers, they should be given, and lubricants also long term, because lubricants, they help clear up the inflammation and they stabilize the tear film. Tear film has already been damaged not only by the disease but also by the presence of preservatives in all the teardrops, as well as because of the disease. So, replacing the tear film is of prime importance. In moderate cases, early addition of disease modifying drugs, which are steroid sparing agents, has to be introduced in addition to all the above things that have been mentioned for mild cases. So, adding tacrolimus long term not only prevents all the disease complication but also prevents complications related to steroid use. Since the disease is of long duration and it is going to stay for years and years, you cannot introduce steroids to these children, as even after using topical steroids for 2 to 3 weeks, the intraocular pressure starts rising. And this chronically high intraocular pressure can cause horrendous complications, irreversible visual loss due to glaucoma, as well as cataracts. So it's better to introduce tacrolimus or cyclosporins in moderate cases, which cannot be controlled by simple measures of hygiene or double action drugs and lubricants. It's rather than giving a short course of steroids, it's better to add tacrolimus for long term use. When the disease becomes severe, with limbitis extending up to 360 degrees of the cornea, then you can have a short course of mild steroids along with tacrolimus and cyclosporin and castor oil. Tacrolimus and cyclosporin, they take about 2 to 3 weeks to control the inflammation adequately. So during that period, steroids can help achieve control of. And when there is a shield ulcer because of giant papillae or cobblestones, then for those you need to have a supratarsal injection of decotron or triamcinolone. Uh, there's a short video present on the page which shows the correct technique of the supratarsal injection. Tacrolimus can be applied on the cobblestone papillae and it flattens them very quickly. So all this management has to be continued long term. So, the take home pearls from this lecture is that accurate diagnosis and grading of disease is important. Patient education regarding the chronicity of disease, personal hygiene, avoiding heat and dust is the key to proper management. Early and long term therapy to prevent flare ups. Cornea needs to be protected all the time by restoring the tear film. Long-term immunomodulation in the form of tacrolimus or cyclosporine should be introduced early in moderate cases. Steroids topically should be reserved only in severe cases and only for 2 to 3 weeks till tacrolimus and cyclosporine are taking over to control the inflammation. Thank you very much for your patience and listening to the lecture. You can leave your remarks or comments at the end of the lecture. Thank you.